As you may have noticed, all three of us have emphasized in our various discussion points the critical importance of timeliness of therapy, that this is a time-sensitive condition. So I'd like to ask my colleagues, as the hematologists in the group, I'm an intensivist and blood banker, so my view on the world is a little skewed in a different direction. What are your thoughts about potential sources of delays in therapy and how we can collectively go about reducing them and providing really important timely therapies for this condition?
I think that's certainly an interesting point, Nathan. I think the delay in diagnosis is a crucial issue. And I think maybe the two main things I run into in why clinicians delay is the first is just the lack of thinking about it. Once they step back and think about the potential, the differential diagnosis and that TTP should be there, that light bulb goes on and they get quite anxious. So just thinking about it, I think, gets you almost all the way there. The other difficulty I see is, it sounds funny to say this, but in centers who have moved up the availability of the ADAM TS13 testing from 5 to 7 days to bringing it in-house where it's back within 1 to 3 days, I've seen situations where they will order the test because they suspect the diagnosis, but they will then wait overnight for the ADAM TS13 activity and not get plasma therapy started, don't get blood bank involved as quickly as they should have. Marie, what do you think?
I totally agree about considering the diagnosis, and we need to alter the way that we explain and teach about this condition. It is a medical emergency. It's one of the main medical emergencies along with MIs and strokes, albeit rarer. And it's down to our laboratory and hematology colleagues to consider it in cases of thrombocytopenia, looking at a blood film and looking at the clinical scenario. The second big area of delay, certainly in the UK, is transferring patients to sites that can undertake plasma exchange and have a level of expertise to look after patients with TTP or acute TMAs. They can be very frightening. They're very sick patients, and it's not for the faint-hearted, and it makes sense to bring them to an area where you have good intensive care, where you have good hematology expertise, but also apheresis team who can manage the difficulties, particularly within the first few days.
I think I'll be a bit on the kind of pragmatic side too. One of the biggest delays that I often see as an apheresis physician is just getting the catheter placed. And one of the sources of kind of collective anxiety that we often see is the placement of a pretty large bore, pretty aggressive apheresis/dialysis catheter in someone that's thrombocytopenic. And I think that needs to be a point of discussion, again, a multidisciplinary and hopefully quick discussion about the safety of placing these catheters under thrombocytopenic conditions. And to some degree, the not trivial discussion about the safety or lack thereof of platelet transfusion in that situation. That's certainly kind of an area of controversy and concern when it comes to this tension between line placement and thrombocytopenia and TTP, whether or not it's safe or not. So I think it's really important to have that discussion, again, as quickly as you can, because unfortunately the patient can get caught in kind of the ping pong between different services about who's going to place the line, or really who doesn't want to place the line, and a patient with undetectable platelet levels. And there certainly needs to be some degree of confidence in those that are doing it, who are used to placing lines under duress. It's not the time for the interns for central line. So there's my perspective. One of the biggest delays, and then lack of communication with the blood bank. All right, because that degree of blood product, 10 to 12 units of plasma, can take time just to prepare, or if you're in a smaller location, even to acquire. So I think, as we mentioned before, just that the timeliness, kind of early communication with your various colleagues that are going to be part of that discussion about initiating therapy is absolutely kind of time sensitive and essential. Don't wait until 2 a.m. to have those conversations, please.
The line issue is very important, and again, that really pulls back to expertise and confidence. It's taken, and it took time for our intensivists and line inserters to appreciate that these patients are prothrombotic. They don't bleed. And we're in a different position to where we were 20 years ago. So, the majority of cases, it's undertaken with ultrasound guidance. It's in a vein, not an artery, unless you miss. And then you press. And, the complication rate that has previously been published, I think, is historic. It's a different setup, and I'm sure you would agree that, Nathan, even from what you've seen over the last 10 years, nobody in our unit ever considers giving a platelet transfer. They don't even ask for it. And I think we have our own guidelines, both in our hospital and nationally, and it would not be considered in this situation. And of course, the guidelines for platelets and insertion of any type of catheters has reduced over time with the improved facilities available. In the old days, when we were registrars, it used to just go in blindly in the neck. The groin's fine for a day or two. The blood bank issue, again, that is very important. We normally contact them as soon as we confirm a patient is coming to us, and they just defrost 5 litres. We just have it, and it won't be wasted. Somebody will use it in the trust, but it's not acceptable, like you've said, to have that level of delay. But I think it's just bringing people with you and communicating before the acute scenario. What's your experience, Spiro?
No, it's very similar to yours. I think the evolution of placement skills technology has helped. I think I also like to tell our teams that all thrombocytopenias are not the same. The leukemic is not producing platelets. The patient with TTP is producing a lot of platelets. They're just being consumed. So I try to tell them it's a different scenario. It's going to be dealt with differently. And if you really look at the line complications, it's not bleeding at the time of insertion. It's thrombosis or infection, which aren't going to matter in terms of your platelet count. So I would agree with you, Marie. It's been a nice evolution over time we've seen with these.
I think it's large part of it does require a conversation and making sure that people understand the reasons for which it's being placed, right? Not, as you, Spiro, I think you hit the nail on the head. Not all thrombocytopenia is the same in terms of procedural complications and hemorrhage, thrombose, or hematoma risk. So I think that does require that consideration of making sure that your proceduralists understand that it's not a leukemic with 2 platelets bopping around their whole body, but someone's actually in a prothrombotic stage, so they can be a little less twitchy about it.
Yes, less twitchy is good for your line.
As someone who places them, I agree.
I suppose we do need to consider the situation for patients that have had caplacizumab. Before, they may have had it pre-transfer. I think that is important because that is a different situation, line insertion. I don't think it's necessarily anything different than we've already discussed, but rather than platelets, in the rare situation, it may need VWF replacement. We've not had to do it, but it's just because the platelets are low, it doesn't mean platelets should reverse that situation. It'd be a VWF concentrate.
All the more reason to have your hematology experts involved in those cases promptly, because those are definitely a nuance that people not familiar with this would have very little understanding of. It's a team sport.